I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
87-year-old with unresectable 3A adenocarcinoma, a 3.4 centimeter left upper lobe adenocarcinoma with mediastinal adenopathy. Genetic interrogation reveals a compound EGFR exon 18, a G719X, and an exon 20, S7681. The patient is not a candidate given her age for radiation and gets osimertinib for 6 months, but with no response, just has stable disease, doesn't feel better, doesn't feel worse. Is there a role here, Dr. Curran, for radiation in these cases? And how do you talk to patients this age? We don't know her fitness level. I assume that's going to make a big difference. We don't know PFTs, but the decision was to start with a targeted therapy given her age, but no real response and not feeling better. Would you talk to this patient about radiation?
Yeah, I certainly think she should be evaluated for it. Again, could be all about comorbidities, performance status, and other factors. The disease that's described here sounds like it's encompassable within a field. I don't feel like we've lost anything by having the osimertinib for 6 months with stable disease. And, she could have, benefit to radiation, whether or not any other systemic therapy is given.
Great. So consideration for radiation here. Dr. Govindan, back to you. If she doesn't want radiation or it's not an approach that's going to be instituted, would you consider other TKIs for these two uncommon compound mutations that are within her tumor?
There is some data that afatinib might be better in some of these patients. Afatinib is no gentle drug. In an 87-year-old, it can cause a lot of side effects. So I think I would start with a lower dose, no more than 30 milligram a day. That's certainly not unreasonable. And if that does not work in terms of or if it's not tolerable or shows no activity, then in my mind, the best chemotherapy agent for elderly is single agent vinorelbine. And that is extremely well tolerated by elderly. There was a study by name Elvis study that looked at this years ago, almost 7,000 years ago, as Dr. Curran would say. And it is certainly very well tolerated. And then finally, in 87-year-old, I think one has to prioritize the quality of life rather than treating a radiographic disease. So I would really talk about comfort care as well.
Great. All very good points for a complicated case here.